I'm Answorth Allen. I'm an orthopedic surgeon specializing in sports medicine at a hospital for special surgery. I am currently the orthopedic consultant to the New York Knicks, an orthopedic consultant to USA Basketball. I'm the former head team physician for the New York Mets and medical director at St. John's University. I specialize in sports medicine with emphasis on knee, elbow, and shoulder surgery. Shoulder is a ball and socket joint which is inherently unstable. Stability is confirmed with the labrum, which surrounds the shoulder socket, and the joint capsule, which connects the ball to the socket. Instability is a reflection of increased translation of the ball relative to the socket. In a shoulder subluxation, the ball moves relative to the socket, but does not completely dislocate. In a dislocation, the ball is completely separated from the socket. Most patients with shoulder instability initially develop instability from a traumatic episode where the shoulder dislocates. This can occur during play, during wrestling, for example, or during football. Oftentimes, this requires reduction of the shoulder either on the field or in an emergency room situation. In an acute situation, the shoulder is reduced, the arm is immobilized for a couple of weeks until the pain resolves, and then the patient is referred for physical therapy to regain their motion and strength. In cases of recurrent instability, then further imaging studies include a CT scan with a three-dimensional reconstruction. This will help us determine if there's any significant bone loss, and this may change our approach to stabilizing the shoulder. Most patients will have instability in an anterior direction. Some patients will develop shoulder instability from repetitive microtrauma. This can occur, for example, in a baseball pitcher or in swimmers. Oftentimes, these patients can be managed with a rehabilitation program. In most patients who have one or two instability episodes, they can be managed successfully with an arthroscopic, minimally invasive approach. This includes repairing the labrum and tightening the joint capsule. In cases of chronic recurrent instability, an open approach is preferred. This includes either a soft tissue reconstruction or reconstruction of any bony defects in the anatomy. The arthroscopic operation is usually accomplished with an interscalene block and light sedation of the patient. The operation will typically take about 1 hour. The patients go home the same day, and they usually require postoperative immobilization for somewhere between 4 to 6 weeks before physical therapy is initiated. The rotator cuff includes 4 musculotendinous units that begin along the scapula and come across to attach onto the humerus. It includes the supraspinatus tendon up top, the one that is most commonly damaged, the subscapularis tendon in the front, the infraspinatus and teres minor in the back of the shoulder. The rotator cuff stabilizes the humerus and allows the deltoid muscle to elevate the arm. Rotator cuff injuries usually occur in patients after the 5th decade of life. Typically, this can be post-traumatic or it may occur insidiously. Oftentimes, patient will complain of pain, especially at night, and weakness of the extremity. This can be quite disabling and will compromise the patient's function. If the patient comes in with a suspected rotator cuff injury, we'll do a thorough clinical evaluation, including a history and physical examination. Imaging studies include X-rays and an MRI scan. The diagnosis is usually confirmed with an MRI. Emphasis is placed on the size and location of the tear and the degree of muscle atrophy, which is an indicator of the chronicity of the injury. We diagnose a rotator cuff injury based on the patient's history and physical examination. The size and location of the tear is confirmed with an MRI scan or ultrasound. Small tears in older patients can be managed successfully with a rehabilitation program, but most people will require surgical intervention because the injury can get progressively worse over time. Surgery is usually done arthroscopically and involves reattaching the rotator cuff tendon back to the humerus. This is accomplished by placing anchors in the bone and sewing the tendon back to the bone. The operation is usually performed using an interscalene block. In most cases, a general anesthetic is not required, and this is usually a same-day procedure. Post-surgery, the patient is immobilized for 4 to 6 weeks before initiating physical therapy. After surgery is performed, the patient is sent home, and they'll be called the next day to ensure that everything is fine. They typically will return to the office for their first post-op visit, usually 12 to 14 days post-surgery, for suture removal, and the next visit is usually 6 weeks later. At that point in time, they'll have started physical therapy, and we can assess their initial progress with physical therapy. The next visit is usually 3 months later, and the final visit is usually 5 months post-surgery before they're allowed to return to full activities. The risk of complications with rotator cuff surgery is relatively low. The risk of infection is almost nil. There can be issues with post-surgical stiffness from immobilization. The risk of re-rupture is a function of the size of the rotator cuff tear. We typically perform 5 to 6 rotator cuff surgeries in a given week. In our practice, we emphasize a team approach to the management of our patients. This includes our athletic trainer, nurses, physician assistants, and physical therapists. We ensure that the patients have a successful outcome by ensuring that all members of the team are on the same page and that we're providing consistent communication and access to us 24 hours a day, either by phone or by email.